going to have a slight change in the list or the order of the scientific talk. So in the schedule, you see Dr. Eli Diamond, but we're going to take the opportunity and invite Dr. Francesco Pegoraro instead to give his talk. He will be having a conversation with us about Erdheim-Chester disease and comorbidities or other diseases that can be seen at the same time. Some people can be living with two conditions and not just one. So Dr. Pegoraro is a hematologist who works at the Meyer Children's Hospital in Florence, also associated with the Scientific Hospitalization and Treatment Institutes. He's an ECD Care Center and clinician investigator, so thank you.
Thank you, Juvi, for the introduction. Oh, wait. Sorry. So good morning, and I'm very happy to be here and give this talk. I'm going to focus on concomitant diseases, and I'm mostly going to focus on three conditions that we often see in ECD. The first, it's something that has already been addressed by Dr. Goyal earlier this morning, but I'm trying to get a bit more into focus. And then I'm gonna talk about some conditions that we mostly see in hematology oncology, and which are clonal hematopoiesis, and I'm gonna go through that, and second cancer. So mixed histiocytosis. As you already heard this morning, we know that histiocytosis are not always unique diseases, but there are some features that can overlap among them, and we can have ECD and LCH, we can have ECD and RDD, we can also have LCH and RDD, and we can have the three of them together. And this overlapping could be a clinical overlapping, but also a pathology overlapping, meaning the biopsies. So today, as I said, I'm going to focus on ECD LCH and ECD RDD. So as I said, pathology overlapping. This means that in the same biopsy, we can have a part of the biopsy which is clearly ECD and a part of the biopsy that is clearly another disease. And for example, LCH. I'm not sure I can, yeah. Here you can see, for example, that this left part of the biopsy is what is the pathognomonic definition, the typical definition of ECD. So this very foamy are called histiocytes, means fat. They look like fatty, and on the other side, it's a very different pattern, which is the pattern that we see in LCH, and this is a very simple staining where when we put antibodies on tissues to see things better, and but there are some stainings that are specific, and for example we have CD1A, which is LCH, and CD68, which is a bit more broad, but we can clearly define ECD. So if we use this staining, and the staining is positive when the figure is brown, we can see that, for example, here we have ECD, very brown staining in the left, and we have this is an LCH pattern which does not stain. And same here, we have these pattern with these large cells that are the same cell we found here, that don't stain for CD1A because CD1A is LCH, and other cells that stain for CD1A. So this is mixed pathology phenotype. And this is another case, and we clearly see in the same, this is the very small magnification of biopsy, and here again we have a clearly LCH pattern here and a clearly ECD pattern down here. But we can also have clinical overlap. And as you already know everything about ECD from former presentation, what can happen in if LCH is overlapping, is mostly lytic bone lesions. That means the bone is less strong. There are some it's not proper holes, but it's more fragile, and that can lead also to fractures. And in this case, we can call this a pathological fracture, and skin lesions. And we're going to see that some of these skin lesions are quite typical of LCH. Of course, we can also have other features, such as lymph node swelling, and also some lung lesions that we can see at the CT scan, which are quite typical of LCH, and that are quite different from what we see in ECD. So just to show some example, here we see what's a lytic lesion might look like. So it's the black is when the normal bone is white. So when it's blackish, that means that the structure of the bone is less solid. And for example, this is what a LCH skin lesion might look like. This anatomical presentation is very typical, and that can present at the same time with the other ECD more typical skin lesions, such as the xanthelasmus around the eyes. But I'm speaking, I've told you about overlapping, but how does this overlap can manifest? There are different ways. The most typical is a patient that has already LCH, maybe as a young adult or a children, and later in life, he might develop lesions that are clearly ECD. And that's the majority, around 50% of cases. But we can also find at the same time, when we diagnose one of the two diseases, we diagnose both. And this is quite common as well. And more rarely, but that's possible, we have seen that in our court. We have a patient with ECD, clearly ECD, that at some point develops, as I said, fractures or skin lesions or other features that can really point towards LCH. So any of this pattern is possible. We also, so moving from LCH to RDD, here again, we can have the histology overlap, meaning the biopsy can be both diseases or also two biopsies of the same patient in different organs. One is ECD and one is RDD. And so we can see it very clearly here. This is from Dr. Razanameli work. And here again, when you think about clinical presentation, the two main features that can point towards RDD are involvement of the testes in males, and again, lymph nodal swelling, which are two very common features. But also swelling of the soft tissues and skin lesion as well. And another presentation which is quite common is the involvement of the kidneys, which is a bit different sometimes from what we see in ECD. It can be monolateral, meaning only one kidney and not the proper infiltration around the kidney, but can have different anatomic presentations. And here again, we can see some examples of kidney involvement, for example, but also we can have bone lesions as we have in ECD. And this is a PET scan of a very recently diagnosed patient at our institution, where we see clearly that we have a very typical presentation of kidney involvement, but also of testicular involvement. And because we know that also mutations are important, we have learned that when a patient has a mixed ECD-LCH phenotype, he almost always carries the BRAF-V600 mutation. And when a patient has an ECD plus RDD phenotype, he very often carries the MAP2K1 mutation. And this is very typical. So what about treatment? This is something that evolves, of course, but historically, when inhibitors were not available, these patients with mixed forms could receive different treatments, and you understand that one should balance what's better for ECD, what's better for LCH, what's better for RDD. So what we learned, and this is information that comes from recent work from our group and from Dr. Diamond's group, is that when you use conventional treatments, the first standpoint is ECD component is the most important to treat. Then, so LCH-driven treatments or RDD-driven treatments are usually less effective than ECD-driven treatments. But if we think of ECD and if we think of what Dr. Arosh told you before, what we learned is that conventional ECD treatments, such as interferon alpha, are usually much less effective in mixed forms. So the message here would be, if we have a patient with a mixed phenotype, we always go for inhibitors because the response rate are much higher. But does having a mixed histiocytosis change the prognosis, change the survival? Probably not. Just trying to explain it very simple. This is a representation of survival. The higher the curve stays, the better it is. And when two curves are one very close one each other, it means that there is no difference. So here we see that there is no statistically difference between patient with ECD alone and ECD mixed with LCH, and this is probably also due to how we treat these patients. We also know that patients with mixed forms do better if they have bone lesions, lytic bone lesion. This might probably have to do also with better diagnosis, earlier diagnosis, and there are also some features that are worse, that bring a worse prognosis, such as that's quite logical, but older age associated malignancies, and we're going to discuss about this later, and of course no response to treatment. But we know that if we treat these patients as we should with inhibitors, the survival is very good. So my second topic would be clonal hematopoiesis, and which is very complex and concept, and I'm trying to make it simple. So hematopoiesis means the building, the production of the blood cells, okay, and which is done in the bone marrow. What we know about hematopoiesis is then you have to imagine the bone marrow as a community of cells, and some cells in this community might get a mutation, okay, a somatic mutation. We have different types of somatic mutation. This can happen at any time in life. It's rarer in children, but it can happen, and it becomes increasingly frequent with age. So one cell gets a mutation, nothing happens. Our body gets mutation all the time because cells divides and gets mutations, and that's normal. That's how we adapt. But some mutation might be worse than others, and if a cell gets a mutation and this mutation gives this cell a survival advantage in the community, this can bring this cell to reproduce more, and this can give rise to a clone. So a clone is a group of cells that share same characteristics, in this case the same mutation, and this can grow, and at some point it gets more mutation, and that can be a problem because that can lead to typical cancers of older age. And this is quite the same idea, just to show you that depending on the mutation, some things can occur more frequently, such as inflammation, or and which can lead to cardiovascular disease, which has been associated to clonal hematopoiesis, but also, as I said, to predisposition to some kind of cancer, especially hematologic cancer. So we know from the work of the French colleagues that patients with ECD frequently have clonal hematopoiesis, up to 40% of patients, and this has been confirmed on wider cohorts recently. So these three mutations are the most frequent in ECD: TET2, AXL1, and the NMT3A, and this is why we usually suggest to look for clonal hematopoiesis in ECD patients. So this is quite a simple thing to do. It's not painless, but hematologists used to do this very often. So it's just a blood sample, but from the bones of the hip here in the back, and then these cells go through a technique which is called next generation sequencing that identifies the mutations usually using a panel, meaning they look for 60 or 100 mutations that are usually found. But again, why is this important? Because this is important because we have learned also that patients with ECD can have a risk of developing other condition, and in particular oncological conditions. So this was first described again by our French colleagues, and they found that up to 10% of patients could develop hematologic neoplasms, and some sort of neoplasms more specifically, something that's called myelodysplastic syndrome or chronic myelomonocytic leukemia. But since then, we have expanded a bit this observation, and we have evaluated a very large group of patients in Italy and France. That's up to 500 patients, and we found that up to 28% of these patients during their life, so that could be before ECD or after ECD or concomitant with ECD, used to have associated cancer. And when we think of hematologic cancer, as I said, myelodysplastic syndrome and chronic myelomonocytic leukemia, and when we talk of solid cancer, that could be the typical cancers that we see often with age, such as prostate cancer in males or breast cancer in females, but also thyroid cancer, which is a bit more common. And as I said, this could be before ECD, but also after ECD, and the most frequent, of course, was close to ECD diagnosis. And you can easily think about this. If you think when a diagnosis of ECD is made, patients go through many investigations, such as PET scans and MRI, so it's a bit easier to identify something that it's not yet evident. And what we also found is that once a patient gets a diagnosis of ECD, there is a risk, there is a possibility of developing hematologic cancer that is quite high at the beginning, but over time it gets stable, while solid cancer can keep increasing, and that's probably due to age as well. We also analyzed, we found that, as I said, 28% of patients can have associated malignancies, but we also compare to the possibility of developing a cancer in the general population, and that's really increased. So it's fourfold risk, and this is even higher if, of course, older age, as it is for any cancer, for multisystem ECD, and that's why I told you before about clonal hematopoiesis, because that's another associated feature. But what we found, and that's really, I think, positive message, is that associated cancer does not mean worse survival, and this is probably due to screening. So how do we screen? How can we screen? It's in most cases the typical screening that many countries do for people at some age. So it's for the for hematologic condition, of course, it would be blood tests, and this is made regularly for treatment side effects and so on, but also bone marrow aspiration, which is recommended at least once at diagnosis or at some point. And what is typical for other conditions such as mammography, prostatic specific antigen. For colorectal, we have the searching for blood in stools and coloscopy, but also thyroid ultrasound, which is a bit more specific to ECD. And of course, dermatologists, because it's associated also with targeted treatment toxicity. So, to conclude, I hope I've explained a bit how the spectrum of histiocytosis can be complex and how these diseases can overlap among them. And I think the main message here is about treatment. So mixed phenotypes require more aggressive treatments in order to get the same life expectancy as other ECD patients. That clonal hematopoiesis is something that we found very frequently in ECD, and we must look for that. We still don't know everything about that, but we are working on that. Our French colleagues are working a lot on that, and I think we're going to know much more in the following years. And of course, the final message is that since associated cancer is frequent in ECD, we have to look for that, we have to diagnose that earlier, and this is the only way. We have to not let these associated condition impair the probability of survival in our patients. So thank you, and I'm happy to take any question.